An elaborate CTG discussion is awaited in the evening. For this discussion, we have Dr. Nusrat, Dr. Mark, and Dr. Georgie with me. So, actually, the first trace, this is CTG of a primary gravida, term patient, low risk in spontaneous labor. Dr. Georgie, can you please comment on this trace?
Thank you, Raji, for the question. So I would go based on the usual mnemonic, what we always say, DRC bravado. I'll look into what risk factor she has. So defining the risk, then whether she is in labor, are there contractions, then baseline fetal heart rate, then regarding variability, are there any accelerations, are there decelerations, and I'll take into the overall picture before commenting on CTG.
Before taking a CTG or while taking the CTG, do you check the machine settings of the CTG machine?
Yeah, definitely, because we need to check whether the machine settings have gone back to the default. So at least see to that the name and the details of patient is on the CTG, and any risk factor and the speed, especially it should be 1 centimeter per minute.
This is just a slide to show how the variability is affected by the change in paper speed. So, Nusrat madam, do you do continuous CTG monitoring for all your patients in labor?
We risk categorize them. So those who come under low risk go for the midwifery care. We do intermittent auscultation only. So we don't. And we have the criteria that, if they find any abnormality, we do put them onto a CTG. If it's normal, they again go back. But the high-risk population, induction of labor comes under high-risk population.
Yes, definitely.
Okay. Yes, so that's the way intrapartum CTG. We do it continuous CTG.
You can get the antepartum and the intrapartum risk factors from the NICE guideline that is updated on 2022. Dr. Mark, we have the FIGO classification, NICE classification and all. Do you prefer any special classification?
It's a great question, and yes, I don't like either of them, personally. We in the UK have been using NICE for a very long time, and it's been criticised for many years for being difficult to follow. Sometimes the 2007 classification was unintelligible. We personally have moved over to physiological interpretation completely, although we do acknowledge some of the NICE advice from the point of view of documentation, but not the interpretation.
Okay. It is not actually the classification that matters, the physiological interpretation of the CTG change that matters. That we'll be hearing more about this during the CTG workshop. Now, before we go to abnormal traces, just some basics. Whenever you comment on the baseline, always take a strip that is devoid of any accelerations and deceleration. Normal range is between 110 to 160, but it can vary in preterm babies. Now coming to variability, it is actually the difference between the highest peak and the lowest trough, and the range is between 5 to 25. Now deceleration, initially we used to classify it as early, late and variable, but it is very difficult to pinpoint to one type. So we can broadly classify it into two types, that is baroreceptor mediated, which occurs due to the mechanical stress the baby is facing, like cord compression and head compression. And second is chemoreceptor mediated ones, which occurs due to the change in the blood composition of the baby. So the first abnormal trace, this is a primary 39 weeks IVF pregnancy, elective induction at 39 weeks. We have done an ARM at around 12:40 p.m. CTG was normal with a good variability, baseline, etc. till 1:48 p.m. After that, we had a deceleration, which was around 3 to 4 minutes, immediately picked up, followed by a more prolonged deceleration. Dr. Mark, what are the immediate steps that you will take when you see such a prolonged deceleration?
Well, the first thing we would do would be to stop the Pitocin, Syntocinon, and to assess vaginally whether there's cord prolapse, abdominally whether there's a uterine rupture or an abruption if possible, change the maternal position, and in my unit, by 3 minutes we'd be transferring to theatre. We're doing what we call an emergency transfer. The idea there is not to necessarily do a cesarean, but if you have to, you'll be in the right place. And it's interesting, if you look at that trace, about 9 minutes, you're bradycardic again. Okay. So that would be a cesarean section.
In this trace, actually, the CTG is recovering very slowly. So we did a PV, she was 8 centimeter. We shifted her to the place of delivery, say by around 9 minutes. Then we noticed that actually the CTG is picking up. If the CTG picks up, can we continue labor or should we expedite at that time?
I think once the CTG is picked up, then you have to have a discussion with mum. And you're 8 centimeters, she is a nullip. So in theory, you've got another 2 hours. And you'd say, well, we can either deliver you now because your baby's had a big shock, or we can see how baby recovers, and if baby recovers suitably, we can continue.
One question, which is your tocolytic agent that you give usually?
Well, the only tocolytic agent I would use in this case is GTM, which I presume is what you call NTG.
Yes, we are giving the same thing. NTG we are giving is an IV bolus only. It's a diluted NTG that we give as IV bolus since terbutaline was not available for us.
We don't give it IV, we give it by a sublingual spray. 2 sprays, it's under the tongue, works very effectively. In the UK, terbutaline is usually the drug of use, but it takes 15 minutes to act. So by the time it's actually acted, it's too late. And so yeah, GTN is definitely the drug of choice.
So actually in this trace, actually we shifted the patient to the place of delivery. Luckily for us, the patient came to become full dilatation when we shifted to the second stage. And we could deliver her by around 2:56 p.m. And you can notice that actually the cord pH has fallen from 7.2 to 7.03, cord blood ABG. Dr. Mark, can you consider this an acute hypoxic insult?
Yes, this definitely looks like an acute hypoxic event. You've got a big separation between the arterial and venous pH. The venous pH is relatively normal, 7.2-ish. And so, yeah, that looks like an acute. With a slight chronic, because both the base deficit, as I call it, base excess, are relatively both high. So you've got a bit of an acute on chronic.
Chronic. So whenever there is a prolonged deceleration, that is any deceleration that is lasting for more than 3 minutes, first thing we have to exclude is the 3 major obstetric accidents, that is cord prolapse, abruption, and rupture. If any one of this is present, you have to deliver the baby immediately in the fastest route possible. And actually, if this has been ruled out, we usually follow the 3-minute rule. That is, if the deceleration is present, we complete our resuscitative measures, that is giving tocolysis, left lateral position, hydration, etc. by 6 minutes. And by 9 minutes, we usually shift to the place of delivery and commence delivery by 12 minutes, and by 15 minutes, we complete the delivery. So we'll go to the next trace. This is actually a second gravida, previous normal delivery, 38 weeks, 2 days gestation, IUGR, third centile with normal Doppler, induced in view of IUGR. We had Foley's induction followed by misoprostol. ARM was done at around 2:30 p.m. Cervix was 4 centimeter dilated, LICO was clear. CTG was going well till 4 p.m. From 4 p.m., we started noticing some deceleration, which was not of much concern in the initial period. But towards the end, you can see that the decelerations are becoming more deeper and wider. So we did a PV at that time. She was fully effaced, 6 centimeter dilated, LICO clear, vertex at -2 station, left occipital transverse position. Nusrat madam, what will be your action plan at this point?
Regarding the management of this CTG,
Yes.
I am not happy with the trace because the amount of time that the baby is having at the baseline is very less. So one of the important things that this baby has a very low reserve because it's a third centile baby, and we as such would not recommend the use of misoprostol in such babies because we do tend to get a lot more of contraction than what we need. So over here, if you see, the amount of time that the baby is staying at the baseline rate is very less. So this baby is going to decompensate very fast. Maybe at this point of time, if you take a look at the number of contractions, there are only 3 to 4 contractions in 10 minutes. It's not hyperstimulation or tachysystole with fetal heart rate changes. I would have made a decision that if the contractions are not more than 5 or 6 and there is a trace this way, this baby cannot sustain the stress of labor, and would put a 30-minute time interval to say, but do intrauterine resuscitation measures as it should be.
What can be the intrauterine resuscitative measures that you can do in this case? Probably no
same-
tachysystole is there.
The same as an acute bradycardia. Because I want to resuscitate this baby, I would give a tocolytic and remove oxytocin if it was there, and then, take a decision to go ahead and do a cesarean
Do you
section.
think that giving oxygen will have a role in the resuscitative measure?
Oxygen is very controversial, but what I have found in a clinical practice is the minute you take oxygen mask and put it onto a woman, the apprehension and the anxiety increases. So a lateral position is much more better along with the resuscitative measures, and then in a very calm environment, move forward, make sure that the theater is ready, and I want to have a delivery for this baby faster.
Okay, actually oxygen has a role if the mother is suffering from hypoxia. In other cases, there is no role for oxygen in case of resuscitative measures. Now, actually, you will be waiting for half an hour with this trace. If the trace is not reverting, what will be your action? You will be expediting delivery.
For this,
Yeah, this
like
trace.
I said, if the number of contractions are not more than 5 and I am having a trace which is this way, this baby will not move further forward. If the contractions were more, I would blame it on the contractions, and that's why the CTG has become abnormal. Over here, there is no abruption, there is no rupture, there is no cord prolapse, there is just 3 to 4 contractions in 10 minutes which are required for me. So if it is 6 centimeters, this baby would not likely go across to do that. Many times the babies come out very healthy, but then that doesn't mean that, we have to teach the team to take certain action at an appropriate in a timely fashion.
Actually, luckily for us, in this case, actually the patient was fully dilated within half an hour.
Yeah.
We expedited the delivery with a vacuum. You can see that there is a slight drop in the pH from 7.2 to 7.02, 7.03. Okay. So we'll go to the third trace. This is a CTG of a primate, low risk. We do elective induction at 39 weeks, and ARM was done at 9 o'clock in the morning. CTG was fine till 1 o'clock. 1 o'clock, there was a small prolonged deceleration which picked up. She was on oxytocin augmentation. This was the trace from 1:10 p.m. to 2:21 p.m. Dr. Mark, do you think these decelerations are of a worrying type?
Yes, they are extremely worrying. You've got a rise in baseline, drop in variability, and your decelerations are chemoreceptor, what we also call late decelerations. So they are indicative of hypoxia.
So actually, by 2:20, seeing this deceleration, we have done the resuscitative measures. You can see that there was increased contractions in the previous trace. So we stopped the Pitocin by 2:20 and did an assessment. She was almost fully dilated. The anterior rim was still present, Leica was clear, direct left occipito anterior. Dr. Mark, at this point, what all things will you do?
At 2:25?
At 2:25, when she is almost fully dilated.
Well, I'm still concerned. If you were doing a fetal blood sample, this would be the time to do it, but I wouldn't, personally. I would be looking to deliver soon or within 30 minutes.
Within 30 minutes. Do you think that we don't have fetal scalp stimulation? If we had fetal scalp stimulation, would that help us to get more time in this case?
I think I think it's unlikely that this baby would respond to fetal scalp stimulation, but I advocate fetal scalp stimulation at every single vaginal examination. You should make it basically second nature. Every vaginal examination, try and stimulate the baby and see the response and note it if it's not there.
After one fetal scalp stimulation, that is fetal scalp stimulation is when we do digital examination, we stimulate the scalp of the baby, then there will be an acceleration in the CTG. So after one scalp stimulation, how much time you will get for the next scalp stimulation?
That's an incredibly good question. I have no idea. I think, like any CTG, it's one piece of the jigsaw. If you get a response to the scalp stimulation, then you've got a bit of time. So you can say, so for example, in this case, you do the vaginal examination, you do the scalp stimulation, you get no response, you go, I must deliver, full stop. If you get response, then you can say, I've got another 30, I'll allow another 30 minutes.
30 minutes, okay. So actually, we stopped the Pitocin, then contractions has decreased, but you can see that decelerations are still persisting and there was a raise in the baseline also. So by 3:30,
Can
she
I add
became.
in, Raji?
Yes, madam.
The number of contractions are very high for this woman. That's something that you know, right from the beginning. So I would try lowering the contractions, whether it's oxytocin or whatever is there. I don't know, because she's fully dilated. I am like a little worried. Are these decelerations, because it's a term baby? It's 39 weeks. It's not an FGR. So I don't know, but if I take a look at the number of contractions, I am crossing 516 in 10 minutes. So I don't know whether this is secondary to tachysystole is what is my small concern that's been there if you go behind.
Usually during the second stage, when the patient reaches second stage, people usually try to increase the dose of pitocin so that they can accelerate the delivery. Do you agree with that in case of when you are having a suspicious or a pathological
I would suggest
CTG?
not doing that, because this baby is struggling inside. The minute I increase it further, I will go into bradycardia. Many times I give terbinafine here also, if I feel that's the reason, and I make sure that the baby is okay inside and wait for a short more time and put an instrument. But it's very important that we make sure that we resuscitate the baby if it is due to increased number of contractions.
Okay. So she reached full dilatation by around 3:30 p.m. Now, since most of the time the PV finding will be dragging us. If it is a 3 or 4 centimeter dilatation, it won't be a dilemma for us. But once she reaches full dilatation, all the dilemma will be starting. So she reached full dilatation by 3:30. Vertex has also descended a little bit to +1 station. So we thought we'll bear her down. We'll encourage pushing. Do you think that encouraging pushing with the pathological CTG is right or not?
No. I think in this case, you've achieved your aim, which I presume is going to be a vaginal birth. So I would say she's now, the vertex is at +1. This requires an instrumental delivery. Get the baby out now.
Okay. So actually she was shifted to the theater by around 4:35 p.m. and she had a trial instrument delivery in the theater at around 5. Baby was delivered by around 5 p.m. And you can see that the cord blood gas pH has dropped from 7.2 to 6.9, and lactate is 11, and base excess is highly elevated. Dr. Mark, can you say that this is an example of a gradually evolving hypoxia? Initial stages.
Well, before you get established hypoxia or chronic hypoxia, everything's gradually evolving. We saw that at the beginning before 2 o'clock. And then from 3 o'clock onwards, it was chronic hypoxia. So if you go back to
I will just start this.
just the one. So in fact, sorry, before then. Yes, so here, so between 1 and 145, you've got the rise in baseline from 140 to 160. So that's your gradually evolving. From 160 onwards, so from about 145 onwards, you've got established chronic hypoxia. That doesn't mean that you've necessarily got damaging hypoxia, but it means that the baby is now hypoxic. Depending on the reserves that it has, will depend on how long it survives that chronic hypoxia, but it certainly wasn't getting any better.
Okay.
And it was also been, then at this stage, you've also got intermittent subacute hypoxia as well, because you've got below the baseline for longer than at the baseline, so you've got a double whammy as well.
So the most important message from this trace is that don't get dragged by the PV findings. You have to set a time limit when you want the baby to be out. If you see a pathological CTG, next half an hour you want the baby to deliver out, you have to set a time if the CTG is persisting like that. This CTG is for Dr. Georgie. Actually, this is a second gravida who was referred to a previous normal delivery, who was referred to us at 34 weeks, 5 days of gestation. She is having IUGR and abnormal Dopplers. This was her we thought that since she is a second gravida, we will go for induction. We took a pre-induction CTG. The initial trace is like this, and this was followed by a trace that shows some shallow deceleration. Dr. Georgie, can you comment on this?
Right. With this background and with the unprovoked deceleration, I would straight away take her for section. I wouldn't go for an induction, basically, for this trace. Because on the background, it is a chronic hypoxia on which the fetus may not tolerate the labor. That's what I think. With the variability so poor and there's an unprovoked diesel.
Can we call this as a pre-terminal trace?
Well,
The second one,
Yeah.
the second one which you showed would be called as a pre-terminal.
yeah.
So when,
The first one has got little variability. It can't be absent, but here you are absent variability with
variability, yeah.
deceleration. So I mean, that the term pre-terminal is not really defined, but if you don't act onto it for in a short more time, you will have an IUFD.
So one type of hypoxia is chronic hypoxia. In this case, the baby is already having IUGR and suffered the hypoxic insult inside the uterus and has done all the compensatory mechanisms inside the uterus. Suppose we are subjecting this baby to a stress, the baby can crash if the baby is going for labor. So we did an emergency cesarean. Baby weight was only 1.4 kg. You can see how the pH was like, it was around 6.9. This baby had some periventricular leukomalacia and seizures in the immediate neonatal period. So I think, actually I'm coming to my last trace. This is a primigravida, low risk, 36 weeks, 2 days gestation. She had all her antenatal scans normal. She reported to the labor room with complaints of decreased fetal movement, no, absent fetal movements, not decreased, it was absent fetal movements. So we took the CTG. This is a trace from 9:40 a.m. till 10:32 a.m. Madam, do you think this is a sinusoidal pattern?
This fits into a classical sinusoidal pattern by definition. And if you see, there are contractions also at the bottom of this. So this trace is usually given about 20 to 30 minutes for an action to take place. How do we differentiate it from a pseudosinusoidal pattern? The pseudosinusoidal pattern will be very different. It does have, but it will be in patches. Sometimes, thumb sucking or any other drug induced. After some time, it will become a little different. So this kind of a pattern, which is very similar and, oscillating up and down without acceleration, without decelerations, is characteristic of sinusoidal.
Can we use time as a differentiating factor between pseudosinusoidal and sinusoidal pattern?
The sinusoidal pattern, once you see, you won't forget it. This is very classical of that. And, if you wait for a longer time, the oscillations keep on increasing till the baby stops its heartbeat. Whereas in a pseudosinusoidal, you will find a short time of this appearing and then moving across to accelerations, very beautiful trace, and that's the way.
Madam, can you tell what are the conditions in which you see sinusoidal pattern?
Fetal anemia, you have, this must be a fetal-maternal bleed, I suppose so. It looks like that. Doesn't give us much time, so most of the time the errors occur because the team has not seen it, does not have the ability to do a very rapid MCA. But we feel that this should be taken up for an immediate cesarean section with the neonatal team being standby for transfusion.
Can we get this in chorioamnionitis or
No, you won't get this trace in chorioamnionitis.
what about abruption?
Abruption is very different. Abruption will follow if you have contractions, multiple contractions, let's say 8 contractions at the bottom. The abruption trace will be decreased variability with late decelerations if you time all of them. It won't be like this trace. So it won't be 3 to 5 oscillations in a minute. This would be like, 3 oscillations in a minute it will go.
Okay. Do you think that ultrasound has, suppose if we saw the CTG for nearly 1 hour, do you think that doing an ultrasound at this point will be beneficial to us? Because when a patient comes directly to the labor room and we say that the CTG is abnormal and we have to do immediate cesarean section, it may not be taken very easily.
This is a trace that requires a very rapid delivery. In my experience, 20 years, we have had a lot of fetal deaths because there was a delay in the team identifying this trace.
Okay. So actually,
Mark,
we
would
also
you like
didn't
to
go.
add in?
Can I just say a couple of things? One, usually this is a chronic condition, not an acute event. And yes, you need to deliver and keep the baby monitored until delivery, but one thing you must have is blood available before you deliver. Because the only thing this baby requires once it's delivered is blood. And you can resuscitate and give what you like, but blood is the only thing it will need, and without that, it will either be brain damaged or it will die. The other thing to say is that in the UK, we use pseudosinusoidal to mean a slightly different thing, and I've got an example in my CTG course this afternoon, which is where you've got an acute bleed. So coming to your abruption, a pseudosinusoidal is a very, very rapid change in amplitude, usually the same kind of frequency, which is 3 to 5 hertz, but instead of 5 to 15 beats, which is sinusoidal, it's usually 15 to 25. So it's a much greater accentuated pattern.
Okay. So actually, we did an emergency CS for this baby by around 10:40 a.m. Baby was a male baby, weight around 3 kg. Baby was flabby, very pale, and the baby died in 24 hours despite multiple blood transfusions. Actually, we did a KB test or Klehoff Betke test in the mother. It showed severe fetal-maternal hemorrhage. So to summarize, always remember Dr. C. Bravado whenever you are analyzing the CTG so that you keep all your points. You don't forget any points. Check the machine settings, especially the time is important, the paper speed is very important. Now, understand the physiology, why the baby is showing these changes. We'll be hearing more about the physiological changes during the CTG workshop. So those who have not registered till now can register for the CTG workshop in the evening. And analyze why the baby is showing the CTG changes. Do corrective measures so that to relieve the baby from the stress that is leading to these changes. If you correct these stress, these factors, in spite of correcting these factors, still the CTG is pathological, then you have to deliver the baby in the safest route that is possible at that time. Thank you.
And now we move on to the next session on instrumental deliveries. May I now invite the lead discussants of the session, Dr. Joshi Joseph, consultant from Rajagiri Hospital, Dr. Saumya, again from Rajagiri Hospital, and our esteemed faculty are Dr. Nozer. Sir is coming to the stage for his first performance today, and along with him, Dr. Jacob, Professor and HOD from MES Medical College.
Hello, hi. Can we start? Hi, good morning, everybody. Dr. Nozer and Dr.